All right, so this is called Welcome Back, Baby. I am Dr. Brownridge. I am going to talk a little bit about when and how to use your frozen specimens, so eggs or embryos. And I'll present for about 15 minutes, and then, as I said, there will definitely be time for Q&A if you have any questions at all. So the egg freezing process, presumably something that you've already gone through. So just as a refresher, this is a process where we initially do some baseline testing, and then there's a 10 to 12 day period of stim meds or injections. And at the end, you take a trigger shot, and then 36 hours later is the egg retrieval. And that's done, as you know, in our operating room connected to our lab. And that same day of the egg retrieval, about 2 to 4 hours later, the eggs actually get frozen after being assessed to see how many are mature. And if you went through the process of embryo freezing, then what happened was that same day, instead of being frozen, the eggs were inseminated with sperm. And then embryos were grown for anywhere from 5 to 7 days, at which point they become something called a blastocyst, and then embryos were frozen at that time. And so that's what presumably has already taken place. So, regardless of whether you have frozen eggs or embryos, the thaw survival rate is pretty high. Nationally, it's probably around 80 to 95%. And in our center, it's on the high end of that statistic. It's about 90 to 95%, regardless of whether you have eggs or embryos frozen. They do great when it comes to the thaw. And as I mentioned, at that same place where the egg retrieval took place, the eggs and embryos are stored on site, right there, the lab connected to our operating room. And that is where the thaw takes place as well. So I want to talk a little bit about attrition. And so the reason why egg freezing or IVF is so efficient, and this was maybe explained at an initial consultation, but the way I like to think about it is, unfortunately, human reproduction is inefficient. So each month that somebody is trying to conceive, there's probably about a 20 to 25% chance of conception. And that is because the body doesn't know how to necessarily ovulate the healthiest egg. And so if you're having regular ovulatory cycles, 12 cycles a year, that would be about 12 eggs in a year. And in an IVF cycle, let's say you retrieve 12 eggs, then that's almost like a year's worth of trying in 1 month. So it just makes the process more efficient, as we say. So here I have an example where, let's say 12 eggs were retrieved for an egg freezing or an embryo freezing cycle, in this case, an egg freezing cycle. And let's say 10 of those were mature. And so on the day, 10 of those mature eggs, mature meaning capable of being fertilized in the future, were frozen. And now we go to do the thaw. So what does that process look like? So let's say 90%, let's say 9 of those eggs survive the thaw. Those eggs would then be fertilized or inseminated with sperm, usually in a process called ICSI, where each egg is inseminated with one sperm. And then we would check those fertilized eggs the next day, which we call day one, to see how many fertilized normally. And usually it's the majority. So here for this example, I put 7. And then we grow those fertilized eggs or embryos to day 5, 6, or 7, up until day 7. That's how long it could take to become a blastocyst. And then we do something called PGT, or genetic testing, where we take a biopsy of the embryo, presumably, and we send that biopsy to a lab. The embryos then get frozen, and we get a result back of how many of those are euploid. Euploid meaning chromosomally normal. And so this is where the attrition happens from a certain number of eggs. Most will survive the thaw, most will fertilize normally, and then we see the drop off for how many will grow to embryos, and how many of those are euploid or genetically normal. And in thinking about this attrition and this euploid rate, this is largely age-based. And so this comes into play when we think about how many eggs we want to freeze initially, and now how many eggs we want to thaw. So the ideal number to freeze and thaw is really age-based. So we see, for example, under age 35, if we were to send a certain number of embryos, we'd expect about 60% to be euploid or chromosomally normal. And then that number slowly, but ultimately drops off to closer to 20% in the early 40s. And so, and the graph on top shows a day 5, a day 6, or a day 7 embryo at the time that it got biopsied. We do know that day 7 embryos have a bit of a lower implantation potential, and they may be euploid less often, despite potentially being quality. And so that's represented in the top graph. And so this information is used to guide us as to how many eggs we initially want to freeze. And in thinking about if there's a certain cohort of eggs, how many we want to thaw to then fertilize. And so once you may be ready to use the frozen eggs, I'll talk in a minute about the general process, some things that need to be done logistically. But what is actually happening is happening in the lab. And so the immediate next step, which takes place in the lab after thawing the eggs, is to actually fertilize those eggs with sperm. And that takes place within a couple hours of the egg thaw. So in general, we pick a day to thaw the eggs and we have the sperm ready to go, whether that's a frozen specimen or it's a fresh specimen from that day. And the eggs get fertilized that same day that they get thawed. And this can be done with partner sperm or with donor sperm, and that donor sperm can be either directed or non-directed, anonymous or non-anonymous, meaning potentially coming from a sperm bank. And once fertilized, as I discussed, those embryos are then grown in the lab for 5 to 7 days. And then we talk about whether the embryo transfer itself will be fresh or frozen. And there are pros and cons to either approach. So when talking about fresh versus frozen, there are different considerations. So of course, we have frozen eggs in this scenario. We may have fresh sperm or frozen sperm, or, and when we're thinking about embryos, these can be fresh or frozen. And so, in thinking about the embryo transfer, what might be the benefit of using a frozen embryo as opposed to a fresh embryo? So if we're using a fresh embryo, that's certainly an option, and then it's one less process to undergo a freeze and then a thaw. But we're not able to do the PGT testing in the case that we're doing a fresh embryo transfer. So the PGT testing is the genetic test, and the reason we then need to freeze the embryo is because it takes about 1 to 3 weeks for these results to come back. And then we get a report. So for example, looking here at this report, this was 9 embryos that were sent, and 4 ultimately were chromosomally normal. And they do usually give sex information, and that can be made available to you or not at your preference. And this is how we usually prioritize which embryo to transfer based on which one is normal and which one is morphologically normal under the microscope. And so that's one of the main benefits of using a frozen embryo, is that we can actually do this PGT testing, this pre-implantation genetic testing, for aneuploidy to see which are chromosomally normal. And so essentially, if we're thinking about, okay, we're coming back to use these eggs or embryos, so what's needed now? Essentially, what's needed now is everything to prepare for pregnancy or for the embryo transfer. And so this would be a series of tests done that were not done as part of the egg freezing process because it was not necessary at the time. For example, a semen analysis to check the quality of the sperm, a cavity assessment meaning taking a closer look at the uterine cavity. This is either done with an ultrasound called a water ultrasound or saline ultrasound, or we can look with an HSG. The top picture there, that's an X-ray looking at the uterus and the fallopian tubes. And this is to make sure that everything is optimized before we're actually doing the embryo transfer, to make sure there are no polyps or fibroids, or potentially we may find a blocked fallopian tube that collects fluid. That fluid sometimes can track back and end up in the uterus and affect the actual implantation from the embryo transfer. And so these would be a series of tests that we do that are sometimes cycle dependent. The semen analysis, for example, can be scheduled anytime. We do follow a certain abstinence guideline, but in general, that's easy to schedule within a week or two. Now, the HSG, or this water ultrasound, that usually takes place in the first part of the cycle, after menses, or if somebody's on the birth control pill. So sometimes this prep takes a few weeks to coordinate. And so these are some of the considerations when we're thinking about, when to come back. What is the appropriate timeline when thinking about coming back to use frozen eggs, for example? And then also a preconception panel to make sure everything is optimized prior to actually becoming pregnant, as opposed to when you're just undergoing an egg freezing cycle, not in preparation for pregnancy. So, in thinking about preparing for pregnancy, we do want to think about optimizing your overall health, potentially starting a prenatal vitamin specifically for that folic acid, and maybe obtaining any medical clearances. For example, somebody may have migraines and they'll need to see their neurologist, or somebody may have asthma and they'll need to see a pulmonologist. We're almost always referring you back to your GYN for your pap smear, a mammogram if that's applicable. And then a preconception consultation is really a conversation that would take place either between myself and you or with you and your OBGYN, just getting everything ready prior to pregnancy. And there are different ways that this can be done. For example, if you start with us, we're happy to refer you to an OBGYN for something like the pap smear to have this conversation, or you may already have established care and a lot of this has already been done. Check it off the list, and then you can come back to us with everything ready to go. And so we kind of work in conjunction, whatever is most efficient and whatever works best for you. And then the genetic carrier screen testing, this is a little different than the PGT testing of the embryo, which looks at chromosomes. The carrier screen testing looks at the egg source and the sperm source for about 400 genes to make sure that there is genetic compatibility, meaning if you previously froze eggs and now you're coming back with a partner to make embryos, we would want to know, for example, does one carry the cystic fibrosis gene, one carries the Tay-Sachs gene? Okay, no problem. But if both carry the cystic fibrosis gene, then there is a chance that the embryo itself could be affected and the baby could be affected with the condition. And so when we're doing this genetic testing, the PGT testing, and we're taking that biopsy, if we have this information already, then we can prepare to also test the embryo itself for this condition. And so we do want to make sure that there's genetic compatibility. So this is a blood test or a cheek swab that's done. It takes, again, about 2 to 3 weeks to come back. So these are some of the considerations when we're thinking about the timeline leading to the embryo transfer. Now, again, many people listening have gone through already the egg freezing or embryo freezing process. So that would be the retrieval. And then for the transfer, we're mainly focused on preparing the lining. We want to make sure it's nice and thick. And we accomplish this usually by giving estrogen pills and then progesterone injections to mimic the normal menstrual cycle. Now, there can also be a protocol where somebody does a more natural FET, frozen embryo transfer, sometimes a fresh embryo transfer cycle, and that would be to follow your natural ovulation, where the progesterone will rise, and we can follow those levels to know how to time the transfer itself. And they are really equal in their success rates, and we kind of just personalize care which works best for you in terms of which approach we should take. For example, if somebody really wants to avoid the progesterone injections, the shots, then there are other options where we can use suppositories, for example. But this whole process is to prepare and to thicken the lining. And this is usually less visits than the retrieval cycle. This is about 2 to 3 monitoring visits. And then we have the date planned for the transfer itself. And so again, about 2 to 3 weeks. Now, if you're potentially planning to do a fresh embryo transfer, meaning you thaw eggs, fertilize the eggs with sperm, and then we're growing those embryos for 5 days, and we're going to take that best embryo on that 5th day and plan to transfer, not freeze it, but transfer it, then the lining prep will align with the egg thaw date so that we can synchronize the cycle. If you're planning a frozen embryo transfer, then it's more convenient because the embryos will be frozen and ready to go. And then the lining prep just takes place, for example, when the PGT results come back or at a time when it's convenient for you. The embryo thaw itself takes just under an hour. And so that's usually a date that we have planned to do the transfer. And then the embryologists are prepared about an hour in advance to thaw the embryo. And so if the embryos were already tested before they were frozen initially, there's no delay. But sometimes people have frozen embryos that weren't genetically tested, and that's something we could talk about, biopsying and getting results, or thawing eggs, growing embryos, biopsying those embryos, freezing them, and waiting for those results to take place. But in general, the lining prep and the physical transfer itself are very similar, basically the same, regardless of whether the embryo is fresh or frozen. And the transfer itself is a relatively easy process, takes about 5 minutes that you're in the operating room. We really only do it in an operating room because that is the room that's connected to our lab, directly where the embryo is coming from. But you're awake for it, unlike the retrieval. And it just involves a speculum and a thin catheter that has the embryo loaded, and that catheter goes through the cervix into the uterus, and then the embryo is deposited or transferred in that thick portion of the uterus under ultrasound guidance. And then you lie down in the recovery room for about 5 minutes and then get up and go about your day. And so that's essentially how the transfer process works. Again, the survival rate is very high for eggs and embryos. And then the transfer success rates are quite high as well once we're talking about either a morphologically normal or especially a PGT tested euploid, meaning chromosomally normal embryo. Those transfer success rates are upwards of 60%. And so those are important statistics to keep in mind when thinking about how many eggs to thaw and how many embryos. If we're working with the number 50%, maybe we're thinking 2 embryos to lead to 1 pregnancy and 1 baby. The statistics tend to skew a little higher, but that is a good way to kind of frame those decisions when thinking about future family planning and family size. And so, just some questions that arise when we're having these conversations that I will answer now, and then you feel free to type in any additional questions. So, when is the latest I can come back for a transfer? In our center right now, we are doing transfers until age 50 and really even up to 55 with no medical problems and with medical clearance. And so that is always an ongoing conversation when we're personalizing care and we're thinking about when somebody can come back for the actual transfer. We do know that the eggs and the embryos do great. They can really stay frozen for decades and maintain their quality, the quality that they had at the time that they were frozen. And so it's really about when is the best time for you to come back and to have a transfer cycle to become pregnant. Do we work with donor sperm banks? We do. We don't work directly with them, but we do have a list of reputable banks that really do an excellent job vetting the donors and quarantining the sperm and doing the genetic testing and checking other factors such as RH and CMV and really getting to know these donors. And this information is usually available on their websites, and the donor sperm banks are very helpful as well. And so let's say you froze eggs and now you want to come back and have a conversation about maybe using donor sperm to either get pregnant or to fertilize those eggs. Then we sit down with your physician, your care team, and third party team, and we talk about the best approach. And we really help guide you through the process when it comes to using donor sperm. Do I need to thaw all my eggs at once? You do not need to thaw all your eggs at once. Again, we take an individualized approach and thinking about statistics and how many eggs we think it will take to get to a usable embryo or 2 or 3. And in fact, we usually we cap it at thawing 18 eggs at once if somebody, were to have frozen more than that, which is a lot. But for example, if somebody has 20 eggs frozen from age 30 and they want to start with thawing 10 of those, that would be reasonable. And there are different reasons why people may do that. And again, we have a discussion and a conversation as to what makes sense for you at this time. Can I do another egg retrieval before thawing my eggs? The answer is yes. Now, this is also a personalized decision and discussion. So, for example, some patients have frozen eggs, let's say in their late 20s or early 30s, and now they're coming back, maybe even with infertility at age 36, 37. We have a discussion. What makes sense? Should we do another cycle and make more embryos at that point with their partner? Or should we thaw the eggs that we have? And that does depend on a few things. Sometimes that's a financial decision. Insurance will cover the egg thaw, but not another retrieval. Sometimes someone will say, you know what, I do want to leave those 8, 12, 20 eggs frozen. I did fine with the cycle. I want to go through the cycle again and, immediately fertilize the eggs and make embryos, and then I'll go to my frozen eggs if needed. Sometimes somebody freezes it, they're late 30s, they're coming back at 43, and that would be a point at which we would recommend, yes, let's do immediately thaw the eggs. And so this is a conversation that we would have to decide what makes the most sense. And it's very individualized, but there's really no wrong answer. If I if I froze my eggs and now I have a partner, can I make embryos? The answer is yes. So if somebody is not ready to conceive, and they have frozen eggs and they're with a partner now and they're thinking about building their family in the future and maybe they want to be kids and they need to kind of map out that timeline, then yes, it is certainly reasonable. We would pick an egg thaw date. Again, we would fertilize the eggs on that same day and grow embryos. We usually at that point would recommend, of course, the genetic testing to know how many of those embryos that we've then frozen are normal, are euploid. So we can think about, okay, there are three, there are six, there is one, and that helps guide us in thinking about if they need to cycle again or the timeline to try on their own, for example. And can eggs be moved from another facility? Yes, in this situation, we do, often work closely with our transport in team. And if in general the eggs were frozen at a reputable center, we do a thorough process looking at the labs and the cycle at that time. And then we help coordinate a courier to bring the eggs to our lab. Again, just like anybody who froze eggs at our center, they would stay frozen on site at our lab until such time that you were ready to use them. And I will just say just a quick word about RMA, which many of you may already know about, but we do have locations in Manhattan, so the East Side office, Madison between 59th and 60th. At the West Side office, primarily 57th and 7th. We have Soho, we have Brooklyn, we have Westchester, Long Island, and we have an amazing team, an amazing group of physicians. And then we have psychologists, we have dietitians, we have genetic counselors, an amazing nursing staff, and there's just a lot of support and an amazing lab, if I didn't mention already, just beyond. And so, for example, if you were to see me in the West Side office but wanted to do some monitoring in Brooklyn, that would be okay, and we'd work with you with that. And this is our new patient concierge number or the phone number to the West Side office and our website. We are always available to help you in any way or to answer any questions. And I thank you very much. I'm going to just stop sharing and just take any questions. I see one here. I'll get started answering. So how do you counsel patients on trying naturally versus going right to using the frozen eggs? Okay, so this is a really good question. And again, this does kind of depend ultimately on your goals. And so this first depends on the age at which you're coming back, against sometimes insurance coverage, and ultimately your ideal family size. And so if somebody hasn't even tried yet, maybe they're 35 and they froze eggs at age 30, should they just thaw the eggs? And again, this is different for everybody. In general, I would recommend trying for a few months if that timeline works for this particular patient. And if nothing's happened in maybe 3, 4, up to 6 months, then we have a conversation. Okay, does it make sense? Do we want to leave the eggs frozen? We can start with our low tech fertility and treatment options, Clomid, IUIs, escalate to IVF, or are we going right to using the frozen eggs? And again, it's an individualized decision, and it does depend on a few other factors. And I've had patients do it all different ways. And so there are many options there. Just going to see here if there are any other questions. I don't see any other questions right now. Hopefully, I have answered all your questions. We are available anytime. Like I said, I'm certainly available. You can call or email or schedule an appointment. Um, and just let us know if there's anything else we can answer or anything we can do to help or more information we can provide. Thank you so much. I do appreciate everyone's attention. I'm going to go ahead and end the webinar, and we're here anytime. Thank you again. Have a great night.